Hi, this is Dr. Harris. I want to welcome everyone to Exam 2 review of Nurse 611. This exam covers weeks content from weeks 5 through 8. Just a few housekeeping tips. Excuse me. The exam is worth 50 points. You'll have 50 questions. It opens on day 2 at 8 a.m. Central Standard Time, and it closes on day 5 at 8 a.m. Central Standard Time. Please be sure that you read all of the directions for the exam. You'll have 90 minutes to complete it with only one attempt. Let's discuss a little bit about the endocrine system. So within the endocrine system, you have endocrine glands that help to regulate hormones within the body. Okay. Different types of hormones include peptide hormones, and these are derived from protein structures, and they are water soluble. Then you have the amine hormones, which are derived from the amino acid tyrosine T. This hormone includes your thyroid hormones, T3 and T4. You also have your steroid hormones, and they're fat soluble. These hormones come from cholesterol. They are not stored. They are released as they're produced. A little bit about alterations of the anterior pituitary gland. The pituitary gland can have some slow-growing adenomas. Most of them are benign. Okay, you can also have prolactinomas. This is a pituitary tumor that secretes prolactin, and these are the most common of the hormonally active pituitary adenomas. Okay, a patient could experience amenorrhea, infertility, non-puerperal milk production, as well as hirsutism in women. In men, for those that may have alterations in pituitary gland, it can cause ED, infertility, and osteopenia. Alterations of the posterior pituitary gland, okay? These alterations include diabetes insipidus, as well as syndrome of inappropriate antidiuretic hormone, okay? With this, we know that there's not enough antidiuretic hormone, which means that water is going right through the patient, okay? There's an inability to concentrate, which means there's too much water being retained, okay? And I will fix these for you as I talk so that they'll be fixed. Okay, so within these two different alterations of the posterior pituitary, with diabetes insipidus, we know that there's not enough antidiuretic hormone, okay? This patient has the inability to concentrate urine. You have a high serum osmolarity and a low urine osmolarity. With SIADH, with this, there's too much antidiuretic hormone, which means too much water is being retained, okay? Many times when you draw labs on these patients, they will show that the sodium is too low. They may be hypervolemic, and they may have weight gain, but it's not considered edema, okay? It's more of a fluid shift. Now, as far as the pancreas, we know that diabetes is a dysfunction of the pancreas. This is where insulin is the hormone of fuel storage. You need to make sure that you are aware of that carbohydrates are the glucose, fats and triglycerides, as well as protein and amino acids. You want to know for your exam purposes how these are functioning within the pancreas as far as diabetic function. Okay. So this slide here, we talk a little bit about what differentiates between diabetes type 1 and diabetes type 2. So we know that diabetes type 1, 90% is from a genetic predisposition, okay? The autoantibodies against beta cells, there's C-peptide test, which can tell you more about the beta cell function. And these folks often have complications with DKA, and they show ketones in the urine, okay? With diabetes type 2, the number one cause of it is obesity. This is an insulin resistant and a decreased insulin secretion by the beta cells. Complications of diabetes type 2 include hyperosmolar or hyperglycemic non-keto state. So there's no ketones in the urine for the most part. All right, so with this slide, it just discusses a little bit about insulin resistance. We know that obesity causes cells to change shape and hide the receptors. There's initial increase in insulin production that causes a downregulation of the insulin receptors. The beta cells will begin to burn out and lose the battle. First sign is postprandial glucose increase, followed by loss of basal control. Okay. Now, this is a question that you want to review so that you are able to differentiate between the Somogyi effect and the Dawn phenomenon. Okay, so which effect would cause you to adjust insulin dosages at night? When you review these questions or these the different material here, or the different side effects, or how these are affected, then you would be able to answer the questions, okay? So we know with the Somogyi effect, those patients have hypoglycemia with rebound hyperglycemia, okay? There's a counter-regulatory hormones that cause glucogenesis, and the most common in persons with type 1 diabetes, mellitus, and in children. You want to check the glucose at 3 a.m. If it's low, you know this is when you need to decrease the insulin at night, okay? So with the Dawn phenomenon, we know that there's an early morning glucose elevation without nocturnal hypoglycemia. You want to check the glucose at 3 a.m. and if it's high, you want to give more insulin or change the timing of the insulin that you're giving. Now, as far as the thyroid, we know the thyroid is a hormone that can affect every cell in the body, okay? This sets the metabolic rate. Many times I tell patients, if you know, those that may have hypo or hyperthyroid, because it is a hormone, it does affect, you know, every cell in the body, and it can, you know, cause the patient to be symptomatic. So we know that the thyroid gland makes and stores and releases thyroid hormone on demand, okay? Iodine is absorbed by the GI tract, thyrosin, or the amino acid plus iodine, and then it's stored as T4, 90%, and T3 for up to 2 to 3 months. Now, hypothyroid versus hyperthyroid. Hashimoto's is the most common autoimmune disorder of the hypothyroid, versus Graves' disease is the most common autoimmune for hyperthyroid, okay? For exam purposes, you do want to know the causes. Whenever you're checking patients' labs, in order to diagnose them with one versus the other, you really need to know what you're looking for with that TSH, or thyroid stimulating hormone, and the T3 and T4, okay? So with hypothyroid, most of the time the TSH is high, and the T3 and T4 are low. With hyperthyroid, it's the exact opposite. The TSH is low and the T3 and T4 are high. Now, the parathyroid and vitamin D work to increase plasma calcium. We know that calcitonin works to decrease plasma calcium. For hyperparathyroid, there's too much calcium. So when you're looking at a patient's metabolic panel and their labs, you might notice that the calcium level is elevated. Okay, and then there's the elevated PTH as well. For hypoparathyroidism, there's too little calcium. So within those labs, the calcium levels may be too low, and then the PTH is too low. What we find sometimes is that if the clinician is not aware of, hypoparathyroid or hyperparathyroid, if the patient's calcium levels are too low, they may advise the patient to just increase the calcium or their calcium intake. However, we really need to, investigate what's the reasoning for the low calcium levels, okay? Because it's not always that the patient isn't, their intake of calcium is too little. So glucocorticoids and Cushing's, here is a perfect textbook picture of what those patients would look like, okay? For Cushing's, we know that there's an increased ACTH from the anterior pituitary gland or an excess production of hypothalamus CRH that stimulates the synthesis of cortisol by the adrenal glands, okay? Pituitary adenomas are responsible for 80% of endogenous Cushing syndrome while excluding corticosteroid use. So patients that aren't taking corticosteroids on a regular basis, we know that, most of the time if they have Cushing's, then the pituitary adenomas are responsible for it, the majority of the cases. Okay. All right, so Cushing syndrome versus Cushing disease. You do need to know the difference between the two. So with Cushing disease, Cushing syndrome, there's a chronic excessive cortisol level, regardless of the cause, okay? Usually from an exogenous administration of glucocorticoids. So for the folks that are on steroids for a long time, for other disease processes, they may develop Cushing syndrome. Now, Cushing disease is an overproduction of pituitary ACTH by a pituitary adenoma, okay? These patients typically lack the inability to increase ACTH and cortisol in response to stress. Okay. All right, now let's talk a little bit about Addison's disease. So with Addison's disease, many times we call it adrenal fatigue. And here on this slide, you can see some signs and symptoms that the patient may display. But with Addison's disease, the corticoids, aldosterone, would show low sodium and high potassium. The glucocorticoids or the cortisol levels would be low, and the androgen sex hormone levels would also be low. Okay. Pheноcytochromatosis, and that is off of the chart. So this is a hormone secreting tumor, and it's most common between the ages of 20 and 50. Okay, most of the time these patients will exhibit some palpitations, perspirations, or some pressure in their chest, which could be considered very, highly emergent. If you look at this figure 2 here, it shows you what the tumor kind of sort of looks like in the right hepatic lobe here. Those are close. No, I got some. But take shoes off. I'm recording. Okay. So moving on to obesity and metabolic syndrome. We know that obesity is the 5th leading cause of death in the United States. Overweight as a BMI is considered a BMI greater than 25, and obesity is a BMI greater than 30. Okay, metabolic syndrome consists of 3 of the 5 symptoms: abdominal obesity, hypertension, elevated blood sugar, diabetes, elevated triglycerides, and low HDL. Okay, so within metabolic syndrome, these patients have an increased risk of developing coronary artery disease and type 2 diabetes. All right, so that was it for the endocrine system. Now we're going to talk a little bit about hematology and cancer. All right, so with hematology, of course, we discuss a lot with the red blood cells and tissue oxygenation. Within this slide here, it discusses a little bit about erythropoietin, which is excreted from the kidneys. And they mark cells for red blood cell production. You do need to know about vitamin B12 as well as folate, and that they're needed for red blood cell replication. Now, iron is added by the liver to red blood cells once they lose the nucleus. And then, of course, you know about hemoglobin. Globin is added to the iron at that point. Okay. The red blood cells live for about 120 days. Macrophages remove older red blood cells from circulating iron, and it's recycled in the spleen or the Kupffer cells in the liver. Okay, so let's talk a little bit about leukocytes, and we know that they're the body's defense mechanism towards infection. Okay, you have the neutrophils, which are the primary defense against infections and bacteria. Then you have the basophils and the eosinophils. Okay, when you have too many neutrophils, you get called to action. The bands can come into play, and this is called a left shift. Okay, you'll understand this more when you start looking at what we call CBC, or complete blood counts. But for purposes of the exam, you don't need to know about left shift and right shift at this point. Okay. Also with leukocytes, there are also monocytes, macrophages, and lymphocytes. We know that lymphocytes are the primary cells of immune response. So at that point, you want to think viral. Okay. Just a little bit about the clotting cascade. You do want to know about the intrinsic pathways as well as the extrinsic pathways. You want to know about factor C and S as they're involved in deactivating the clots. So diseases that are affected by the hematology system, there's von Willebrand. We know that this is the most common hereditary blood clotting disorder, okay? Also hemophilia, and it's an inherited genetic disorder, as well as factor V Leiden disease. This is an inherited genetic disorder. In relation to anemias, you do need to know the difference between relative anemia as well as microcytic anemia and macrocytic anemia. Also, aplastic anemia versus acute blood loss anemia. Now with leukemias, we know that acute lymphocytic leukemia is the most common childhood leukemia, and acute myelogenous leukemia, or AML, is the most common adult leukemia, okay? We know that leukemias are malignant disorders of the blood and blood-forming organs. Also, you want to know about the classification. It's predominantly in the myeloid or lymphoid cells, and the rate of progression for leukemias can be either acute or chronic. All right, here you want to know a little bit about Hodgkin's versus non-Hodgkin's. This is a great slide that differentiates the two. We know that 10% of the diagnosis for Hodgkin's would be Hodgkin's, and 90% would be considered non-Hodgkin's, all right? Non-Hodgkin is the most common. Within this slide, sorry, go back. Within this slide, you can also see how you would, the nodules or the nodes that are involved for a patient with Hodgkin's versus non-Hodgkin's, okay? Now, heparin-induced thrombocytopenia, or HIT, the hallmark of heparin-induced thrombocytopenia is thrombocytopenia, okay? This is a decrease of approximately 50%, and the platelet count is seen in more than 95% of individuals, okay? It is immune mediated, and adverse drug reactions can be caused by IgG antibodies, okay? Disseminated intravascular coagulation, or DIC. This is a consumption of blood clotting proteins. The underlying cause could be sepsis or cancer. The clots can cause organ failure. You do want to know about the clotting factors as they are related to DIC. All right, so let's talk a little bit about immunity, stress, and infection, and cancer. So what is the hallmark of infection? Okay, so your immune system, this is the first line of barrier is considered your skin. The second line is an inflammatory response. Okay, so when we're looking at the inflammatory response, you want to look at the cardinal signs, which include redness, pain, swelling, and heat. You also want to know about the cascades and the goal is to prevent infection. So with this slide, it goes through the kinin cascade, which increases permeability and brings help to the site. And then it goes through to complement the cascade and find and destroy intruders, such as the neutrophils. And then it goes over to the clotting cascade, which contains the debris. And then it is activated by the tissue damage. Okay, so as far as the kinin cascade, histamines, they increase permeability. Bradykinin is for heat, and prostaglandins, just pain. Now this slide here, I did throw this one in. It just shows the pathway, the complement the pathway in 3 ways. This is not something you'll be tested on, but it is something good to know. Same with this slide here. Okay, so systemic inflammatory response syndrome, better known as SIRS, refers to the consequences of a dysregulated host inflammatory response. Okay, it's clinically recognized by the presence of 2 or more of the following: a temperature greater than 38.5 degrees Celsius or less than 35 degrees Celsius, heart rate of 90 beats per, greater than 90 beats per minute, respiratory rate greater than 20 breaths per minute, or PaCO2 less than 32, as well as WBC count greater than 1200, or less than 4,000 cells, or greater than 10% of immature band cells. You'll know more about the WBCs and the immature band cells, that kind of thing, whenever you start looking at CBCs, okay? SIRS can result from a variety of conditions such as autoimmune disorders, burns, surgeries, thromboembolism, pancreatitis, as well as vasculitis. Now, adaptive immunity antibodies, you have your B cells and you have your T cells, okay? You might want to know, for exam purposes, what part of a child's immunity is deficient in relation to these antibodies, and it would be the B cells. And for how long? And that would be for about 6 months, okay? They're still growing. All right, so this is just a knowledge check for you. You can go through this. If you had a patient that was deficient in T cells, what would you worry about? Also, if you had a patient who was deficient in B cells, what would you worry about? Now, you do need to know about active and passive immunity. 2 examples of active immunity would be getting vaccinated. That's one example, or getting the disease, okay? 2 examples of passive immunity would be you get protected or as a baby from the mom, or you get the immunoglobulin shot. And then you want to know what's the difference between natural and acquired immunity, okay? Natural immunity is your body being exposed to getting disease or obtaining it from the parent, okay? Acquired is when you get the disease from an outside source, like getting it from being vaccinated or from an immunoglobulin. Okay, so here it just talks a little bit about antibodies. Your IgG, IgM, IgE, and IgA. Sorry, you do want to know about these antibodies in relation to the IgG is the most abundant. IgE, usually if you're drawing labs, you would see this is related to an allergic response or anaphylaxis. IgA is in secretions. And IgM is the first responder of acute infections. Now, you do need to know about hypersensitivity reactions. What would be considered a type 1, a type 2, a type 3, and a type 4, okay? Now, here are some examples of what you would need to know as far as sensitivity types. Just be mindful in regards to hypersensitivity. You don't want to confuse that with allergic reaction versus a sensitivity reaction because they're two different things, okay? Now, let's see. So here's another like knowledge check. Give an example of each. So an example of autoimmunity would be considered like lupus or Graves. And an example of alloimmunity would be considered organ rejection. Now, as far as how the elderly are affected in relation to autoimmunity or immunity, we know that there is a decrease in functioning cells. Would do what for the elderly person? It would make them more susceptible, okay? If there is an increase in autoantibodies, what would it do? It would make the person more susceptible to an autoimmune disease, okay? If you had the elderly that was had a chronic disease, what would it do? It would expose an elderly person to having more complications, okay? Now, exotoxins versus endotoxins, we talked a little bit about this earlier. You do need to know about gram-positive versus gram-negative. Gram-positive exotoxins are gram-positive versus endotoxins are gram-negative, okay? You also need to know that endotoxic shock can lead to death. Now, here are some bacteria here. You want to know which bacteria would be considered gram-negative versus which one would be considered gram-positive, okay? All right. So here's a little bit of information about HIV. We know that it's considered a retrovirus. So what really is a retrovirus? Okay, a retrovirus is a virus that inserts a copy of its RNA genome into the DNA of the host cell, therefore changing the genome of that cell, okay? We know that HIV can be found in breast milk and body fluids, but blood is the greatest threat. We also know that HIV turns into AIDS when the CD4 count drops below 200, or the patient is immunosuppressed, and there's quite a bit of immunosuppressant disease presents itself. All right, so talk a little bit about GAS, or general adaptive stress syndrome, okay? This is when your body reacts to stress and the sympathetic nervous system is affected, okay? So there's an alarm. Your body tries to resist it or adapts to it. And then if it can't do that, your body gets exhausted from trying to fight off any kind of infection, okay? All right, so stress hormone The stress hormone is considered cortisol. We know that cortisol mobilizes glucose, amino acids, lipids, and fatty acids and delivers them to the blood. We also know that anxiety can elicit the sympathetic nervous system response, okay? And this slide just talks a little bit about cancer and for more mutations. This is not something that'll be on your exam, but it is something to know. You do need to know a little bit about tumor markers. So for screening purposes, the PSA is the tumor marker for prostate cancer, CA-125 for breast or ovarian cancer, catecholamines for pheochromocytoma, and the AFP is for liver cancer. As far as viruses that are responsible for cancers, we know that HPV is responsible for cervical cancer, so that's why it's important for young folks to get vaccinated for HPV. We know that Kaposi sarcoma is the virus responsible for the cancer that usually folks that have HIV have. We know that chronic hepatitis B or chronic hepatitis C can cause liver cancer, and chronic Helicobacter pylori can cause stomach cancer. Okay, so signs and symptoms. The most commonly reported symptom of cancer and treatment is fatigue. Sometimes those patients can exhibit pain and cachexia. Many times they are anemic and they may have leukopenia or thrombocytopenia. Or sometimes they could have some infection in the lymph nodes that don't easily resolve. So what causes death within the tumors and the cells? The primary tumor or the secondary tumor? The secondary tumor is considered metastasis, okay? What is neovascularization and what does that mean? So with neovascularization, that's when new blood vessels are kind of sort of, I want to say, recruited to the site. So when you have a bad cell, the cells are trying to revascularize themselves. How long can cancer cells live? They can live forever. And cancer cells, they can reactivate telomerase so that they can live forever. So that's what makes them kind of continue to stay into the body system. All right, and this is just a slide that shows you how tumors are staged, okay? You won't have any of this on your exam, but this is for good knowledge. All right, so let's talk a little bit about the cardiovascular and lymphatic system. So this should be just a review. The cardiac function, you have the right heart is responsible for pulmonary circulation. The left heart is responsible for systemic circulation. We know that diastole is the atrial contraction of the mitral and tricuspid valves opening, and systole is the ventricular contraction of the aorta and pulmonary valves opening. A little bit about electroconduction. We know the SA node is the pacemaker of the heart. The sympathetic nervous system, the increase in heart rate is caused by lowering the threshold of action potential. And with the parasympathetic nervous system, the decreases in heart rate by increasing the threshold to the action potential. Now this slide just shows you a little bit about ventricular action potential. So acute coronary syndrome, you do need to know this. You need to know about stable angina versus unstable angina, as well as the cardiac markers. You also need to know the traditional clinical classifications of chest pain, and they're listed here. Now, as far as a myocardial infarction, you need to know the difference between a STEMI versus an NSTEMI, okay? And you also need to know about healing after myocardial infarction. So what happens with the heart? What does it look like? We know that the collagen matrix is deposited and it's weak, mushy, and vulnerable. Patients can develop acute pericarditis, and cardiac tamponade can develop, which is compression of the heart by pericardial fluid. Now, valvular disease, very common. You know, patients can have aortic stenosis, mitral stenosis, as well as mitral regurgitation. So you do need to know the difference between these. Also need to know about congestive heart failure. What's the difference between dilated cardiomyopathy versus restrictive cardiomyopathy? Which one of these is considered a systolic dysfunction versus a diastolic dysfunction, okay? Which one of these is the most common? Which one has a normal ejection fraction, okay? Hypertrophic obstructive cardiomyopathy. You need to be aware of this because many times we're doing young folks sports physicals, and this is when we typically find this. And if we're not finding it, it could lead to death. So please be very mindful that this is one of the most common inherited heart defect disorders, okay? And it's most common through the autosomal dominant inheritance. All right, here's a little bit about atrial fibrillation and what your EKG would look like with these arrhythmias. So with AFib, it's the most prevalent cardiac arrhythmia. It affects 1 to 2% of the general population, with about 10% incidence at the age of 75. So we know that AFib has multiple adverse clinical implications. And if you look at this EKG strip, this is not going to be on your test, but just looking at this EKG strip shows you the difference between atrial fibrillation and the fibrillatory waves versus atrial flutter, which looks like sawtooth wave patterns. You also need to know about the classification of paroxysmal, persistent, and permanent cardioversions. And then you know a little bit about aneurysms, and just know that there are a true aneurysm. All 3 layers of the arterial wall are affected. Okay, you have the adventia, you have the media, and the intima. Okay, if there's a false aneurysm, there's an extravascular hematoma. Okay, so you can see here with these pictures what the true aneurysm looks like versus a false aneurysm. So pericarditis, myocarditis, and endocarditis. Pericarditis is the most common that affects the pericardium. The myocarditis is an inflamed or inflammation of the myocardium, and endocarditis can be caused by damage to the valves, and it's common for staphylococcus infections are the cause. Now, peripheral artery disease, you need to know the difference between chronic edema versus PAD. So many times patients will come in with circulation issues or swollen lower extremities. So you need to know which one, which disorder is responsible for that. Okay. So for a patient that has chronic edema, we know that this can be caused by faulty valves in the vasculature. For peripheral arterial disease, the cause of it is ischemia, and many patients have pain with walking. They have decreased pulses and their legs feel cold. Okay. Hyperlipidemia. So hyperlipidemia, there are free radicals can cause damage to the LDL. The macrophages try to, get rid of some of those cholesterol particles. When you have too much LDL, that can cause damage to the heart or the blood vessels rather. You can also see in this picture here what your blood cells should look like versus what happens when you get plaque buildup, which is considered atherosclerosis. Okay, too much plaque buildup, you don't have enough room for blood flow to go through, which can cause heart attacks. Okay. All right, so that's all I have. I wish everyone good luck on your exam too. I know this is a lot of content to cover from weeks 5 through 8, but I will just ask that you focus on what the question is asking you. There's nothing in the questions that are, we're trying to trick you with at all. But I think you'll do well on it. And if you have any questions, please reach out to your instructors. Thank you. Have a good night.